Good morning. Finance Committee will please come to order. All right, welcome. Okay, any citizens wishing to address the committee this morning? There being none, way ahead of you. There being none, we'll move on to approval of the minutes from the January 25th meeting. I'll entertain a motion. We have a motion by Mr. Bose, second by Mr. Petty. Any changes, modifications? All in favor, please say aye. Aye. Opposed? Motion passes. Item 4, CFO report. Ms. Clark.
Good morning. I don't really have any items other than the January financials for this morning. Okay. So. So for January, our admissions were right on target with budget, and our case mix was also slightly higher with the acuity of our patients. I did want to point out at the bottom right graph, our length of stay by month was abnormally high. Just as a reminder, the length of stay is calculated on discharged patients. So we had an unusually high number of patients that had been here over several months. So that is kind of an anomaly for January. This month, our emergency department was 1% over budget. But if you looked at the trend, we were 400 over where we had ended up last month. And needless to say, it was an extremely busy month in our emergency department, but our budget had reflected a higher expectation. Urgent care, you can see, saw the highest number of visits in our 3-year trend. In January, we saw over 5,200 patients through the urgent care. And this month, I also changed the 2 right graphs. Previously, I had reported our overall clinic visits, and on the bottom, we had a indicator which showed more of it was an overall outpatient visits number, and that was a really convoluted number in my opinion. It wasn't showing you a whole lot. It had radiology visits combined with outpatient surgeries, combined with a lot of other things that didn't add well together. And as we looked at clinic visits, we had within this committee several questions about, well, exactly what's going on in some of these clinics. So what I did is I split the clinics between primary care and specialty care. And included in the primary care is our community health as well as the school-based clinics. And then all of the other specialty clinic visits, including women's health, is down in the lower graph. And so hopefully these numbers will be a little bit more meaningful for you as we progress through the next few months. And then you can see that both of these happen to be about 2.5% higher than budget. Our clinics were extremely busy this month. Does anybody have any questions about the new graphs? Okay. Our observation cases were slightly down by about 5% from budget, but as you remember, we had a lot of admissions and a lot of patient days. So Observation cases are actually inpatient beds, so it makes sense that if you have a lot of patient days, inpatient days, that your observation cases may be a little lower because there's so many beds available. And then our invasive lab cases were over about 3%. Again, the highest in our 3-year trend. Inpatient and outpatient surgeries continue to be below budget, but we are seeing a slight increase from the prior month. In the psychiatric area, our patient days were really strong, about 4.5% higher than budget, and our clinic visits continue to be under budget. Again, the budget is very aggressive, about 19% under. Our psych emergency visits were 8% under, and PHP is about 5% above our budget.
Steve, can I ask a question? Sharon, on the inpatient surgeries, is that a function of just fewer cases, or are we having issues getting suites scheduled and difficulties with getting people in suites again?
Anecdotally, I'm going to say that we are looking at scheduling, but it's actually fewer cases. The cases that are needed for inpatients are getting done. I think where we reschedule due to conflicts would be on the outpatient side. And I think as we get our new surgery schedules and our new surgeons acclimated, that we will start to continue to see increases in efficiencies and all of that start to work out with higher cases.
Okay, thank you.
And then under our financial metrics, we did receive about $180 million this month for the ad valorem revenue, our property tax revenue. And you can see a nice spike in our days cash on hand. It's up to 248 days. Our net AR continues low at 48 days, which is favorable. And our FTEs per APD is at 5.71 compared to our overall year target, which is 5.8. And this is favorable as well. We're actually working fewer FTEs than we had budgeted.
Ad valorem revenue on budget.
It is on budget. Yeah, we are tracking that. You know, if just for conversation, if you go back for the last 2 or 3 years, the estimates are very, very close to what actually comes in, and we'll be tracking that very closely this year as well. So our connection enrollment, much as we expected, due to the ACA enrollment, the decline that you see here is really related to those patients that are insured that apply for our Connection Supplemental Program, which they have to re-enroll in the ACA, and that is effective in January. And so there's a lot of re-enrollment, and as you can see, if you go back and trend that, we have that natural decline each January in those numbers. We do work with those. There's a whole campaign that we do in October, November, December to try to reach out and inform, hoping that that decline will be minimal, but it appears that that is a natural occurrence in every January. And then we'll start to see that slow incline back up. So for January, the bottom line from operations, The medical center lost $187,000 compared to a budget of $565,000. Most of this is due to lower volumes that are occurring in the medical center. And this month, we did have a slightly unfavorable payer mix. If you look at that very top line, right here, you can see that our net patient service revenue was $1.7 million behind budget. And again, our inpatient revenues were pretty strong, but our outpatient revenue was about 3.5% under overall. And then combine that with a slightly unfavorable mix with a little bit higher self-pay population this month, and that's where that $1.7 million occurred. But we do have some favorable offsets down in other operating expenses. You can see that we've got some large savings in supplies. A lot of those supplies are in the surgery areas. As you know, surgeries are very expensive when you start to look at implants. We also have some timing going on with some purchases, and there's some significant savings in a lab program that we are continuing to outsource. So that's kind of offset in another category. I did want to mention back up in salaries. You can see that those costs are slightly unfavorable. However, we do continue to hold the monthly FTE per APD is at 5.6 compared to a budget of 5.8. So again, we're flexing staff well. And benefits, we were slightly unfavorable in our health insurance for employees again this month. We had several large claims that occurred. So those... Well, contract labor, because of some of the inpatient volumes that we're seeing, some of that is creating contract labor, and then there are also some hard-to-fill positions that we are filling with contract labor. As you can see, we don't budget for much contract labor at all. So there are some open positions. Volumes and extra shifts that are being filled, but a lot of the contract labor is unplanned, and we don't really allow people to budget for that. So that's just kind of a natural overage. And then as those positions get filled from a full-time status, you'll hopefully see that go down. Are there any questions on the month of January? If you look at year-to-date, the medical center is at $1.3 million year-to-date, $2.3 million budget. So we're about $1 million behind for the 4 months on income from operations. Our net income is at $3.5 million so far. The differential there is really our mark-to-market on our investments. Hopefully by year-end, that will correct itself.
We're all hoping for that.
Yeah. So a claim, they continue to be about 5% under budget for build encounters. That is due to some open positions in the areas of family medicine, neurology, dermatology, psych, and ENT. They are working on recruiting in all of those areas. Our net operating expense per encounter, you can see, is favorable. The red line is budget, and the blue line is where we are on a monthly basis. But year to date, they still remain about 7% under budget on average per encounter. If you look at their January performance, it is favorable to budget, a loss of $1.4 million compared to a budgeted loss of $1.5 million. Again, most of the variances that you see on the screen are related to the 5% underage for encounters. If you look at, again, net patient revenue, they were 11% under. They too had an unfavorable payer mix for the month of January, similar to the medical center. Their favorable salaries relate to the fact that they have a lot of open positions that they are recruiting for. And then if you look over year to date, they are favorable at a $5 million loss, about $200,000 compared to their budget. Are there any questions on a claim?
I had one question in your executive summary. You stated an overestimation of the GME funding. Did we not get some state funding, or are we?
So the way that, let me explain that's kind of a two-level question. Let me explain what that statement is talking about. When we went through the budgeting cycle for a claim, what we're talking about is the GME funding that the medical center pays to a claim for their time, for the physicians and the clinicians' time. The contract is still being negotiated. And there's two components to the contract, and it sounds relatively simple, but it's a complex discussion, right? You have what the hourly rate should be for the physician and what the time should be. You know, how many hours in dedicated time should be compensated for. So what happened during the budget process is just as a placeholder, when we created the budget, and the budget resides at the same amount on the medical center and in a claim. When we did it from the acclaim side, we looked at the physician compensation, but what the true rate should have probably been is something more of an academic time, not what the physician was making from a clinician time. So we overestimated the hourly value for the GME. And so for this year, when you look at the budget side of things, the budget is going to be too high. It is intercompany, but as we accrue for what should be paid, we've identified that that was not the right number for budget, and we're accruing at that lower rate, so it'll be correct when the contract gets signed. So you're going to have a budget variance, but what we're accruing in the actual column is going to be closer to what the actual agreement, and
Okay.
the cash transfer will actually happen.
All right.
Does that answer your question?
Mm-hmm.
Okay. Are there any other questions?
Okay, no more questions for Sharon? I'm sorry, do you have more?
Oh, I was just going to point out.
But wait,
I always
there's
do
more.
that, don't I?
Oh, yeah,
Just
foundation.
on the year-to-date total, I can't see it here.
Not trying to
covered up.
rush you at all. Don't get that feeling. Just, we love listening to your descriptions of our financial situations.
It's my 1 hour,
And
Steve.
we want to give it to you.
So for net income, we do have a combined total of a $1.2 million loss for all three entities on the medical center for the year. And that's it. Sorry about that. Didn't mean to interrupt.
Sorry to step on your clothes. All right, any more questions for Sharon?
Can I ask you, Chuck?
Yes, sir.
And this is education on a claim. We have a way of graphing showing the actual physician encounters versus what a fully staffed, adjusted, full, physician slate would be if we had all the folks that we needed in the appointment potential that they represent. You see what I'm saying?
Sorry, I didn't hear the question.
My question is on a claim because I mean.
Turn your mic on.
I'm sorry.
We measure, we measure a claim basically by volume and not so much by performance when it comes to the graphs that we see. The question is, we've gone a long time with the claim and we continue to see, we continue to see graphics that depict fewer physician encounters than what we had hoped we would have due to a number of factors, not least of which is staffing. So the question then is there a way to take a fully staffed claim and assume adjusting patient panels to a fully staffed level and comparing that to the physician encounters actual versus potential? And would that help us understand the gap that exists by not being able to get all the physicians in and get all the staffing done?
We can do that. We can give you a projection of what we would anticipate a new physician. Remember, when you hire a new physician, they don't come on board and they don't meet their expectation immediately, right?
Sure.
You have to ramp them up depending on,
adjust it.
right?
I understand.
So we can do that for you. It won't be, we would need to consider that. We would
Is
need to
it-
do some kind of a factor to say there's a ramp up time as we add physicians.
Is it a legitimate observation, Diane?
Well, it is. I think there is a legitimate observation, and we do track by physician their budgeted encounters and how they're performing, right?
Yeah.
And then we would have to consider their time off and all of the things that they do,
Yeah.
what we've
Yeah,
allotted.
no,
But
you'd
we
have
do
to
track
adjust
it. We do.
But the real piece that you're looking for is not the discretionary piece, it's the non-discretionary piece.
Correct.
You want to be able to see what the potential panel would look like and the impact on the system were it to be
Fully staffed.
And the goal being to encourage and to make sure that we all understand what that
Might look
delta
like.
is
Yeah,
between actual encounters versus potential encounters.
Yeah.
If it's not a huge deal,
okay.
I'd be interested in seeing it.
Okay.
If it is a huge deal, then
We'll work on
we can
it.
talk offline or
Yeah.
whatever. if you
Well,
want to.
we can work on it. I don't think it's a huge deal. We'll work on it.
Thank you, Diane.
Okay.
Thanks, Trent. Any other questions for Sharon? I'd like to entertain a motion to accept the CEFO's report. Motion by Mr. Bose. Second by Dr. Weber. Any further questions? All in favor, please say aye. Opposed? Report is accepted. Thank you.
Thank you.
And keep your seat because you're up for a couple of more. Did you want to make an introduction?
Yes, I do. Members, I wanted you to meet Dr. Kramer. Dr. Kramer is Med Exec's appointee to this committee. He's going to sit in on this committee, and I wanted you to know him. Dr. Kramer is also part of our OBGYN department. He's an acclaimed doctor, doing a great job for us, and so I didn't want you to think that he was just here because he had nothing else to do. He has a lot to do. So I wanted to introduce him to y'all, and y'all during the break can get to know him better. But he's a good person for the organization.
Great. Welcome, Tim. And you can sit at the microphones if you have questions. We'd love to hear from you. And so,
And you can establish which side of this you want to sit on, because they seem to sit in the same areas. You decide you want right or left.
we go where we're told. Welcome. We look forward to working with you. Okay, Ms. Clark, item 5B.
All
Approval
right.
of the network provider agreement.
I have several managed care contracts to present to you this morning. The first one is Magellan Healthcare. As you may know, we have, the state has put out for bid the Medicaid STAR program that will look for new managed care organizations to be in Tarrant County beginning in January of 2020. One of those that have submitted a bid is Magellan, and if they do win the bid, we will be in network for Magellan under this contract for Star, Star Plus, and CHIP.
Any questions for Sharon? And a motion by Mr. Bose, second by Mr. Nguyen. All in favor, please say aye. Opposed, motion passes. Item C, please.
The second one is Global Health Holdings. This is a new Medicare Advantage product. This is new in Tarrant County. They are waiting on TDI approval, the Texas Department of Insurance, so we're not sure what the effective date of this contract will be.
Okay, any questions for Sharon?
DT, put on your mic.
Do you know how many lives do they have?
We are not sure how many lives will be covered since it's a new product and it has not been approved yet. It's likely going to be not really marketed and sold. So until that point in time.
Oh, I see. Is there any service SLA requirement for improvement on their part?
I'm not sure about,
The reason I ask is the health plan star rating is like 3.5, and on the drug plan it's 3, so it's kind of average.
okay.
So I'm not sure if they are flexible in terms of certain drugs and stuff like that that needs to be looked at.
DT, is that the star rating from Medicare?
Yes, the Medicare Advantage. Yeah, they know 3.5 for the Part C, and then 3 for the prescription side. That's a concern I have because we have some kind of unique patient, and if they're unwilling to look at the drug for a formulary or stuff like that, a patient may not get to where they need to be, but they know, so I don't know. New to the market, they're not new in Oklahoma.
Yeah, they're just new to Tarrant. We can continue to look at that and I can follow up with you on that question.
And also, do they have the ability to look at the RAF score? Do we have the ability to do the RAF score challenge and stuff like that internally?
I would have to follow up with you on that as well.
Okay. All right, any other questions for Sharon? We'll entertain a motion for approval of this item. Motion by Dr. Weber. Second by Mr. Petty. All in favor, please say aye.
Aye.
Opposed? Yes, sir.
Propose.
You're okay, we have one opposition, Mr. Nguyen.
And why is that DT up?
I just don't have enough information because of the star rating and the ability to be flexible with the patient on the drug plan side and all that stuff.
Fair enough.
I can't support it.
Fair comment.
Okay. Motion passes. Item D, please.
D is with Provider Network of America. This is a commercial product for JPS. It is a TPA for self-insurance plans. This is a relatively new product in Tarrant County, and if approved today, this could be in network for JPS by May of this year.
Okay. Any questions for Sharon? Entertain a motion on this item?
Is there,
Oh,
is
question.
switching from a current TPA or?
No, this is a new product for JPS altogether. It's not like a name change or,
Can you elaborate a little bit on the new product? What is,
excuse me?
can you elaborate a little bit on the new product? What are we doing with this TPA? What do we do with this TPA? When you said new product?
It's fairly new to Tarrant. It's not a new, I do not believe that Provider Network of America is new. It's just kind of moving into Tarrant County,
And so
and it's new for JPS.
TPA.
Mhm.
And do they have provider network in place or they start the new one?
Excuse me?
Are we looking at because we need new network, provider network in the network or?
This would put JPS in network for the TPA for the self-insured plans that sign up with Provider Network of America. It's not a large group within Tarrant County currently,
Oh, I see.
but it is a commercial product at commercial rates.
Have we looked to see how many of the patients that we have previously is our network?
Well, TPAs are a little bit difficult to say you would be in network versus out of network with, you know, if you had come before, if you would be in network, we wouldn't be accessing Provider Network of America. They would just be out of network for us. So they would not have been registered as Provider Network of America. So we wouldn't be able to tell if they would be in this network if they were here before. TPAs are a little bit different than if you just had a traditional United or Blue Cross affiliation.
So any new provider network that we would be encountering, to the extent that they had a TPA, we would need to have a separate contract with that TPA for that new network. Is
Well,
that right?
correct.
Okay.
Yes.
Because they kind of go together in this case, right?
Well, so a TPA allows, it's kind of a contracting organization for the smaller, and it might link in someone that's outside of the DFW area to access care.
Third-party administrator.
So it would allow, like a bigger geographic coverage a lot of times. So people may not be accessing their primary care here. It might just be an expanded geographical coverage. So again, these type of contracts may or may not bring a great deal of volume necessarily. They could. It just depends on how the smaller self-insured plans access through the TPA.
It just, I mean, it increases in-network
Yes,
service potential
yes.
for JPS.
It does.
Yeah.
Do you know how we get to such a low rate? Because they only pay 140% of Medicare allowable for a TPA. That's a little bit low from what I normally see.
You say it's low?
Yeah. Because usually commercial, these are commercial. These are pretty low for commercial rate.
If we would talk about rates, we could move into closed.
Okay.
Would you like to table this for now and talk about that in closed?
Yes, please.
Okay,
Okay.
so we'll do that. We'll table this item and circle back to it in a
Yeah, I
closed.
think anytime we want it, which is a very fair question, anytime we're talking about the negotiation of a rate, it's probably best that we have that discussion. So, because then you're going to provide all that knowledge to everybody in the industry. It's a little challenging.
It's published here, that's why I asked.
Sure. No, I think it's fine. I think we can discuss those and how we got to those and why we got to those and what difference that is from some of the other payers and go from there. It's very fair.
Okay, so we'll table item D
Table this one.
and move to item E. Good morning, Katie.
You can turn that little square one on. There you go.
Is it on?
It's on.
Good morning, how are you? I'm here to request approval for a contract awarded through an RFP for Transunion Healthcare, doing business as eScan. These guys won the bid against 3 other vendors. They are an incumbent. They do a great job for us. They do coverage discovery. So what happens when there's a self-pay patient later in the rev cycle, 45 days past discharge, the patient may not have called us with their updated insurance information. These guys do a really good job of looking for Medicare, Medicaid, commercial insurances through some proprietary software. They've found us heaps of money, so we're glad about that. So we're here to ask for approval. Through the bid, they did offer us a reduction in their contingency fee and an annual cap reduction. They are paid when we are paid. So once they discover the coverage, we bill that coverage. Once the coverage is paid, then they receive contingency. So it's to their advantage to hurry along that process so that they fall within the filing deadline.
So do they do the identification before we bill the
Yes.
carrier? Okay, so it's
Yes.
kind of a prepay verification
No.
of, I
Well-
mean, pre-bill, I guess.
And this
Yes,
is, should be post, right, not pre.
I'm sorry.
This is, should be post, right? After.
We pay them after we get paid.
Pay as post.
No, I mean,
The
but
s- the
we,
service-
they identify
the
the other
service
coverage before we bill.
So they're self-pay patients. The self-pay patient would have gotten a couple of statements during that period of time when they're looking for insurance for us.
And what is the day that they start doing?
45,
this?
day
45
45.
days past due.
So 45 days after the day of discharge, we send them the self-pay account. So that gives us 45 days through statements and other processes to collect that information. What we're finding is some of the patients are applying for Medicaid or other insurances at other hospitals or a HHSC field office, and we may not be aware of that. So what happens is eScan finds that information and allows us to bill the Medicaid.
What happened when, because I think, if I'm not mistaken, the Medicaid eligibility contract allowed them for 90 days, right?
I'm sorry, I don't understand the
The
question.
change contract and the other contract to look for Medicaid eligibility has a 90 days.
So
So
our
it takes 45 days, and those guys are still working on it. Who's taking the claim, and are we?
whoever finds it first. And the Medicaid eligibility companies, Change and Change Healthcare and MedData are not reimbursed for coverage discovery. So if they find an active Medicaid, not an application that they've provided, but an active Medicaid, that's a courtesy back to JPS.
But
If they are working on an application for us,
here's the challenge, right? You may have up to 130 something or 40 days to, you track down the patient, fill out their eligibility and apply. And that process may take 130 to 180 days. And here you have someone coming in 45 days, but they may look back further that are actually the work of the other group that are doing all the work, and they just identify and we bill.
right, so with our
How's that going to be coordinated
Yes,
to
so
keep
our-
people honest?
Right, so our eligibility vendors do provide that information to us. Whoever gets the information to us first is sort of takes the credit for it. So if MedData and Change, through their eligibility process, assisting patients with the application, don't realize that patient's covered, and maybe they get to us at day 50, and eScan gets it to us at day 45, eScan gets the contingency. And both companies are aware of that.
I don't think that's how the contract was read the last time we looked at it from Change and MedData,
Okay,
because they also have workers' comp and all that stuff, right? So that will take a long time for eligibility, and then here's somebody who just picked up and run through the Medicaid or the commercial database and pick that up.
but if the patient hadn't been qualified, eScan's not going to find it.
I'm sorry, can you repeat that?
If the patient doesn't have an active recipient number, with either vendor, they're not going to be able to discover that.
It's a matter of timing, because they bounce off of the Medicaid eligibility, right?
Right,
And the Title
yes.
VII, Title VII, Title VIII, and all that stuff,
Mhm.
right? So somebody might make a determination and apply and went through all the work, and these people can just hit at the right time and will pick up.
Yeah,
And
So-
they get credit for something somebody
So
else
we
is
look to
doing.
see if there's an active application from Change Your Data or MedData. But again, it goes back to, we have asked those vendors to tell us immediately when that patient is certified.
So are you concerned that we would be paying twice, or are you concerned that they would be able to
Or
get
we give
the
to
credit
wrong
for it
person,
without?
And that'll get us in trouble down the road to audit. I'm
But
not.
would we actually be in a circumstance where we would be paid twice if they're already
So,
checked
so
out on their
DT,
Medicare?
remember that Change and MedData are actually in our Epic EMR.
Right.
So the moment that they are aware that they have eligibility, they change within Epic. So if that's changed within Epic by those two vendors, there's no need for us to actually even go out and use this vendor. So the two vendors that you're talking about that are actually trying to gain eligibility through an application process are working within our system and have access to our system on a daily basis.
Those would never be
And those
put into
should,
this pool at all.
correct, those should be, if they're doing what they should be doing, they're real time. And that pay status would be immediately updated from self-pay to Medicare and Medicaid. And we would never go to Transunion eScan to even look for eligibility. So it should not be a problem. And contractually, it is not a problem because that's already written that way in the contract with those two vendors.
There's another vendor in the mix also as well, because you have another vendor that we approved a few months ago that went in and looked at the bad debt and trying to do recovery also as well.
Which one was that, DT?
I forgot the name.
You mean
Right.
bad,
That does look for,
you mean our collection company,
yes,
right?
because
Sorry?
I know eScan, so, and then there's another company, that's why the last time when I approved that, they said it won't interfere with eScan, but I don't think that's the case. Because I've always had problem with too many vendors touching and claiming. And then when they submit and we may not cross-reference, there's no way we can cross-reference. And
So our bad debt companies will have gotten that information after the filing deadline. So I'm not sure, within the rev cycle, they wouldn't get the account in a timely manner to, even if they found insurance, it wouldn't be billable, the way the cycle has flowed.
It is a complex timing and handoff process, but Transunion has been the incumbent, and we've been doing this process with Change and MedData and with the bad debt vendors. And at least to my knowledge, and Katie can speak to hers on the front line, we've not had any disagreements that have made it to me about, well, gosh, that should have been in my contingency fee versus another vendor's contingency fee. So the process seems to be working well, at least over the last year, under these three current vendors that we've had.
my biggest challenge is, because Medicaid is a monthly enrollment.
Is Medicaid,
It's a monthly enrollment.
okay,
And then once you have somebody, but under the Medicaid eligibility, they only look for those that are already here, the service render. And then the number may change and then leave a certain claim that are deemed to be self-pay, but they are not really self-pay. It's an administrative error on our side, and then somebody went in and scanned and picked that up. So I'm struggling a little bit on that. Okay.
Any other questions?
No, I think,
tell me exactly what you're struggling with.
Sure.
it's too many vendors looking at the same thing.
Okay,
And I haven't have a clear path of who on our side. I haven't seen a clear answer how we're going to determine who. They haven't complained doesn't mean to me that they won't down the road. And it's just, I'm not sure who will take credit for the amount of work, or do we credit the right people for the work that is doing on the self-pay population to find insurance? Because there's at least 3 or 4 vendors, 5 vendors that I've seen so far.
Katie, have you experienced conflict among the vendors in terms of sorting out the
No,
credit?
we have very candid conversations about, it's the timeliness of the reporting to us.
Let me ask a question, because DT, you are in depth in this, because part of this is a lot of the areas that you deal with. So you're going to see things that some of the other board members are not going to see, and you may well see things that we don't see. Is there profit or value to us being able to spend a little time with you and understand and get your concern? If there are concerns that we don't have answers to, then there should be a concern with the contract. If there are concerns that we can talk you through and you go, oh, okay, I get it, or we get it, is it valuable to take this and have some time to discuss with you? And I know that your time's been challenged, but is it valuable to spend time with you, and then we bring this maybe back to the full board? Because I understand you all have a time frame, obviously, to deal with this contract, but I don't want to do a contract that you've got serious reservations to, and you're going to have your colleagues that are going to want to defer some of their opinions to you, because you're an expert in this area, and we get it.
The value for eScan is there. I'm not questioning the value for eScan.
Sure.
My trouble is to make sure that we do our part to credit the right vendor. And I don't think we somehow it's just confusing for me to
Okay.
credit the right people at the right time, because
DT, are you, after having reviewed those contracts, do you think there's a contract inadequacy in terms of being able to accurately differentiate where that credit should go? I mean, is it something that can be remedied in the contract with eScan?
well, this area is a little bit more complex. I mean, we all know that. So, but I think we have too many chefs in the kitchen to handle. And
Well, I hear you, and we may, but my question is, what's the remedy? I mean, is the remedy a contractual remedy, or is the remedy something else?
I think it's more contractual.
So would it be valuable for you and for the board and this network to pull this contract down, allow you some additional time to review, and then bring it back before the full board? Because I'm on the same page Trent is, and that is, if there's a remedy, I want to put it in place. If there's not a remedy, then this may not be a contract that is valuable to our patients and to JPS.
Why don't we do this? Go ahead and get approval, and then the next time up for renewal, let's map out the strategy around that, so that we either streamline or make it a little bit more clear.
Well, I would go one step further than that. Why don't we do this? Why don't, if you all as a board feel comfortable with this, you can either approve it or not approve it here, but if you do approve it, you have between now and the full board for you to spend a little bit more time reviewing it, and then recommendations and amendments can be made at the full board level. That way, we don't have to wait until the next time of a contract. We can fix it now.
Yeah, I agree. We don't want to enter into a contract.
To a contract
that may
that-
have some
I agree.
material flaw.
I think it's the contractual language may have to be reviewed by legal, because I'm not qualified.
We got one of those.
To look at
Okay,
that.
sure, and we're fine. That's what we pay legal for, so we're good. They're happy to do this.
Well, I
So-
just have a question. My question is, this looks like the third contract that have come to the board where we're going to be giving companies information at 45 days. To go after self-pay, because this seems like the third. Maybe the question should be, how many do we have now? And somehow that 45 days click in for all the companies that y'all have brought before us. So it looks like, to me, we have 2 or 3 companies that's working on this self-pay.
We do have quite a few companies working on self-pay because we all know that's our
Right.
biggest opportunity. And I can put together a timeline for you guys so you can see where the vendors fall within that
be
rev
great.
cycle.
Right.
Yeah,
That
we
would-
could do
that
that.
would help.
Before
And
we-
it'll
helpful
have
for
all the
board
days.
members.
Yeah, sure.
And then I think if we can look at the overall strategy, so that a board member's not sitting here saying, I just keep getting contracts and it looks like they're doing the same stuff, and to DT's point, too many chefs in the kitchen. Or maybe we say, in order to make this, you need that many chefs in the kitchen for an area that we have significant opportunities in, which you as board members would want us to take proper opportunities where they come. So I think we can do that. So my question before y'all as board is, if you want to consider approving this or not, that's y'all's call. If you do approve it, then I think we have that time period between now and the board meeting to, one, make sure legal can get us some answers, and make sure that you can diagram a few of those, and you can name the chefs that are in the kitchen, to use that
Right.
analogy one more step further, which y'all are tired of hearing about.
Right. And one of the deals, I believe, when I read in part of this information, one of the justifications for doing this company that we was going to reduce our AP, but I didn't say by what percentage or how many days, so
Yeah, AR,
AR, right, AR.
it's going to have some, but
Yeah.
potentially have some material impact on the amount of money that we get back and the time that we get it back.
Right, so.
Yeah, that's the reason why
So
we do
what
this.
what it'll help with is those self-pay patients now will have a coverage that we can resolve through a insurance payment.
Exactly right. That's why we do this, right?
That's
To
what-
make
I
sure-
understand that, but I was trying to find out if we say that's our reason, what are we projecting that
Yep.
decrease is
Yep.
gonna be?
Yep.
It's in there as a part of this product, and I'm
Right.
just saying, what is the,
So this is
what is your target?
This is a existing vendor. This is an incumbent. So if we were not to have this service, you would see an increase in the self-pay population.
Okay,
So it's more of a strategy to keep that increase from happening, because this process is currently happening today.
well, maybe my question should be, what is it now? Where are you now? You adding, you've got two other companies. What is our number now, and
Sure.
what are you targeting it to be?
Sure.
That's all I'm asking.
Sure,
That was
sure.
one of the criterias you had for going with adding this company. It was in there. I can't pull it up. I circled it so I could have my question, but I can't pull it up on my system today.
Well,
That's all
and
I'm
in that-
asking.
In that time, in the timeframe that you're putting together, I think what helped me is what stop gaps are in place that eliminate the potential for any duplication, or, and frankly, if there's still holes. Even after we have 2 or 3 companies looking at it, I'd like to know that too. I mean, how many do we have to have before we feel like we've actually, plugged the die?
You know,
Exposure to this industry is that it's not unusual to have multiple vendors.
yes,
I mean,
and it does, AR feels like one big piece of
Yep.
the pie, but we will get kind of we'll map it out
Yep.
so that you can understand each one of these vendors is highly specialized and comes in at a different time frame during this process of collections. And it's a fairly standardized process within our industry. So give us an opportunity to do that, and I think it'll make a bit more sense and clarification.
yes, we do approve this, and we move to full board for further vetting out some of these details.
Will it give y'all
Yes.
time between now and the board meeting?
And DT,
Sure.
if you could do us a favor, and I know your schedule's really tight, but if you can give us a little bit of time to meet with team and express what your, not only concerns and issues are, that would be hugely helpful for us, and that will help us better direct legal. And we can do that. So the combination of what you've got, then getting answers from legal, I think we'll be very prepared coming to board, and that will give you all a second look at it.
We'll get wrapped up
Well,
before the
yeah,
board.
a couple of things. One is, since DT is flying back and forth to California, we can just fly to California with him.
Okay.
I don't know about that, actually.
Board meeting in La Jolla? I like it. We're there.
The other question, I have one other question is, and it even stuck even more when you said the company is an incumbent company.
Yes.
One of my concerns is, and I'm asking that we maybe look at the big picture. I just happen to pick on you today, is that that our MBE, WBE policy is way below. I mean, we're system-wide, we're like 8%, 9%. And so I guess my question is, even though there were 3 other bidders, how close was this bidder to the other bidders, and did any of the other bidders comply?
I don't believe so, but I can double check that
Okay.
for you.
And then I guess my question is, if this bidder is an incumbent bidder, and they've already been working with us, why are they now still not in compliance?
I think I can answer that. This is a pretty big organization, part of TR, Transunion, so it's that corporate is pretty big, so it's kind of hard to pin. I mean, they're publicly traded companies, so it's kind of hard to answer that question.
Yeah.
Okay.
Versus the plan.
I don't remember, I'm sorry. Yeah.
No.
No, I understand what you're saying, DT, but they're in agreement to seek to comply. They're asked to submit a plan on how they will comply, unless I'm reading it wrong. Is a demonstration of effort to include Hub SB MBE businesses. So my question is, why are they still there? And I guess I'm asking that for every company that we check that second block. So I would just ask that we would look at that and not just be in the mode of just continuing checking the block.
Okay.
It's this type of work that they do is very complex and require large system to bounce with all Medicare, Medicaid system and commercial. It's almost impossible for a smaller company to get to that size to be able to address what they're trying to do.
But they never will get there if someone doesn't start asking. And so that's all we're asking is that we have a plan that says that they will give us a plan on how they can do it. None of them will ever do it if someone doesn't ask. And so they are our current vendor, and all we're doing is ask how. There are some of those other specialties out there, but they never get in because no one ever pushed that button. That's all I'm saying, so.
Okay.
Okay. Any other questions for Katie or Sharon? Okay, entertain a motion on this item. Motion by Mr. Nguyen to approve. Second by Mr. Bose. All in favor, please say aye. Opposed? Motion passed.
No, I wanted to pass first. So my understanding is this will not be on consent agenda at the board meeting.
Yeah, we'll just
Yeah,
action item.
Knowing
Good
that,
point.
knowing that these have come up, we won't put these on
Yeah,
consent.
Okay.
typically they do, but let's make sure we don't on that. That's a good point, thank you.
I have one other question that we talked about every time we have an RFP issued, is that as though construction, when they do RFPs, when they come with their recommendation, they have their score sheet that shows how all of them met. I ask again, can we do something uniform so we will get that? I mean, that also helps that in looking at the stuff. All of them have a form that says, do you do this, 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 and this? And only construction comes with that, and it's an excellent identification, real quick to see all the questions. Some of them have vendors, some of those have gone out to try to find vendors. They have all that on their form. And I'm just asking that we as a board kind of come and look at that when we do RFPs, that overall summary sheet come to us.
Let me ask a question about that. Is there a difference between the form that we would have them submit to us in the case of a bid versus the form that they would submit to us in the case of an RFP? Because I recognize there's a difference, and I thought that difference was because we were talking about the professional services that would come as a result of an RFP as opposed to the requirement to provide that information by a bidder in the case of a bid. Not that we couldn't get them both, but I understood that was why there was a difference between the two. Is that wrong?
No, you know, we can have a discussion, I think, if we wanted to, when we moved into close for this other discussion. I think I would be more comfortable there.
Okay. I'm just thinking that there is a form that y'all look at that it comes back and that does become public information. It is not giving out anything, but it is your selection criteria that I'm asking that you show. That is what
Oh,
I'm
the
asking.
selection criteria?
Yeah.
I'm sorry, I thought you were talking about the actual form where they produced that said this is the
No.
number of
It's
employees.
Angie's form, it's Angie's form.
Okay, I got you.
And if we
Angie's
can
form.
figure out a way to make that apply to
Okay.
all RFPs, then I think not only is that fair, it can be
Scoring form.
helpful.
Right.
If we can do that and it is an apple to apple,
Apples, yeah.
yes. If it's not apple to apple, we put an asterisk and say, this did not apply for this process because.
Right.
And I think that's
Right.
very fair.
Okay. Okay.
Motion passes, thank you.
Thank you. That was fun.
Gina, hurry on up here. Come on.
Come on down.
Decided to come up.
No, I know. You ought to. I enjoy seeing everybody's face out there. They're going, oh, I'm on the agenda too.
I'm next.
We're buying some rubber gloves, I see.
Yes, we want to buy some gloves, please. We have we're presenting to you a contract to purchase gloves from Halyard. Halyard is a previous vendor provider, and they're a current vendor provider for other things like caps, gowns, and so forth and so on. So we would like to roll in the purchase of gloves from Halyard also. Just some notations, they were a previous provider. We did go out in RFP about a year ago and found another vendor to provide gloves. That glove, once we implemented that product, was not to our expectations. And so we have turned back to our previous provider, Halyard, and this is rolling that purchase back into that contract.
Are these stuffed parts of a GPO or anything like that, or do we just?
Yes, they are.
Oh, yeah, okay, awesome. Any questions for Gina?
Move approval.
We have a motion to approve by Mr. Petty,
Second.
second by Mr. Bose. All in favor, please say aye. Opposed, motion passes. Thank you very much. Ms. Peebles. Good morning, Wanda.
Good morning. I have two contracts.
Sharon warmed up the seat for you. Sharon warmed up the seat for you. Yeah.
Two contracts for you this morning to present. The first one is with Specialty Care Cardiovascular Resources. This is our perfusion contract that we use for our open heart surgeries. We did put this out for an RFP. However, they were the only company that did respond to the RFP, which is fine because we're comfortable with their services. They do a great job. They are always on time. They know our physicians. They know their pump settings, and so we felt comfortable with renewing this contract for this. It is part of our budget.
It's in budget. Any questions for Wanda? Entertain a motion.
Approval.
Motion by Mr. Bose.
Second.
Mr. Nguyen, all in favor, please say aye.
Aye.
Opposed, motion passes. Thank you. Item H.
This is for the second phase of our Telecenter program with Avasure. We started this project back in 2015. We implemented 10 telesitters at that time. This gives us the ability to have one person watch 10 different people who would otherwise require a one-to-one sitter. It's not for everyone, but it's for confused patients who may be trying to get out of bed. It's a goal to try to prevent falls on these patients. The person can actually speak to the person in the bed and remind them if they see them starting to get up to lie back down, or they can contact the nurse to go in the room right away to try to prevent falls. We currently have a block of 10 telesitters right now, and one person can watch 10. So our goal now is to expand that to the next 10 so that we can avoid having to have one-to-one sitters with these patients.
Okay. Okay. Any questions for Wanda?
Wanda, is this the total amount, or is this the amount for the expanded section of it?
No, sir, this is a total amount.
Okay.
Entertain a motion.
So moved.
Second.
Motion by Mr. Petty, a second by Mr. Bose. All in favor, please say aye. Opposed, motion passes. Thank you, Wanda. Jamie Pillai. Good morning.
Good morning.
Understood you weren't busy with JCO or anything like that last couple of weeks, kind of been hanging out.
So that's behind us. Good morning. In March of 2016, we had 2 severe storms that produced hail. Our insurance provider, Zurich, evaluated all JPS-owned facilities and estimated the total replacement cost value to be $2.2 million. Subtracting the $693,000 payment we received for the patient care pavilion roof repair, which was approved by the Board of Managers and completed last year in April, and subtracting the $100,000 deductible, it leaves a balance owed to JPS of $1.4 million. So we issued an RFP and received 3 bids to repair the hail-damaged roofs to 22 of our facilities. DMW Design Group was the lowest and best offer. I'm requesting the Finance Committee Board of Managers to consider approval of the proposed commercial construction repair agreement between JPS Health Network and the DMW Design Group Incorporated for the repair of the hail-damaged roofs throughout the district.
I think it's great. My question is why does it take so long? I mean, this was 2 years ago, right? That this storm actually happened? Why does it take so long to get this done?
So after our emergency repair to the pavilion roof, we went through our competitive bidding process and entertained multiple vendors' bids, and just by process alone, it took this long.
It's a long time. It's a long time to get a bid to fix roofs.
Yeah.
While we're waiting, is there any additional damage to it as a result, or just?
So unfortunately, using this week as an example, with some of the torrential rain that we received, about 3 of those 4 roofs are experiencing leaks.
So move.
Motion by Ms. Petty, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Jamie.
Thank you.
Oh,
Mr.
I'm
Chairman,
sorry.
no,
sorry.
to Trent's response, I don't know if anybody else has experienced this, but I will say one of the most difficult insurance companies to deal with is Zurich. We just redid our entire church, and it took us that long because they sent engineers out. They wouldn't buy into the facility, so I could relate to that experience. I know it takes so long, but
Good
We have
point.
Jamie on our side.
We have Jamie.
Jamie on our side.
Jamie?
All right, thank you.
Appreciate you. Thank you, Reverend Emerson. Melinda, item J.
I am delighted to be here this morning and see you all to discuss the annual renewal for a product called Midas. We've been using Midas for the last 8 years. It is used by the quality department. It's recognized as the market leader for maintaining information associated with core measures. It's how we report our core measures. Any physician measures that we're reporting, any patient safety incidents, and any patient complaints. A marvelous product that we've been very happy with, and it is budgeted. And there was no increase for this annual renewal.
So this is well within your ability to approve. It's budgeted.
So,
It's it's an incumbent provider. Why do we have to have this on the agenda?
Because it's
So
over
we-
50, so it's got to.
Over 50? I thought it was 200.
Well, you've got to approve the bid exemption.
Oh, the bid exemption.
Right.
Okay.
okay.
Bid exception. Did we also get the bid exception approved on item H?
I don't think we did.
We approved the motion, but not the,
That's right.
Bid exception.
so we'll go, thank you for noting that. Why don't we take up J and we'll come back to H. So what we need to approve first is the bid exemption, and then approve the request. So I'll entertain a motion for the bid exemption. Motion by Dr. Weber, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes.
Thank you
Now-
very much.
Oh, sorry, hold on, is it, one for a second?
The bid exemption
Pardon
from
me.
Glenn Design.
And then now we'll actually take the request itself. Entertain a motion for the request. Motion by Mr. Nguyen, second by Mr. Bose. All in favor, please say aye. Aye. Opposed? Motion passes.
And thank you again.
Thank you, Melinda. Let's go back to item H and request consideration of the approval for the exemption for competitive bid. Entertain a motion.
So moved.
Motion by Mr. Petty, second by Mr. Bose. Any questions? All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Ms. Clark. All right, let's go into closed, and then, any matters of legal?
27 contracts were negotiated under $200,000.
Okay. We're going to go to closed and take up item D real quickly, and we'll come right back out. All right, we'll reconvene in open session. Thank you all for your participation. We're going to return to item D, item 5D on the agenda. We've had some opportunity to talk about it. And are there any questions for Sharon before we entertain a motion? All right, I'll entertain a motion to the will of the committee.
Recommend approval.
We have a motion by Dr. Weber,
I'll second it.
a second from Mr. Petty. All in favor of the motion, please say aye.
Aye.
Opposed? Please note, Mr. Nguyen opposed to the measure. The motion passes. All right, there being no further business for the committee, we are stand adjourned.